Welcome to Dementia Air, a content channel devoted solely to exploring topics related to dementia. Dementia Air is a production of Beyond Dementia Coalition, a not-for-profit 501c3 which seeks to reduce stigma and help all of us not only recognize but also accept, assist, and embrace people living with dementia as valued and beloved members of the community. See the person beyond the disease. My name is Bruce Leyton, and I'm your Dementia Air podcast host. Joining me today is Ashley Trammell, cognitive nurse navigator at Northeast Georgia Physician Group. And Ashley is a registered nurse with a Bachelor of Science in Nursing and is a certified dementia practitioner. And Ashley, I hope that we'll find out more about that position and what it means as we go through this discussion. So today we're diving into a critical and kind of what I perceive as an often overlooked moment, the reality shifting experience of receiving a dementia diagnosis. And Ashley, I'm going to ask you also to hold my feet to the fire if I mischaracterize anything as we go through the day or this session and our discussion. So typically an individual being diagnosed is accompanied by a loved one, a spouse, a child, or sibling who suddenly finds themselves stepping into the role of a caregiver, something they never imagined, never planned for. You know, they might have been looking forward to retirement and traveling the world, and maybe that changes for them, maybe not as they navigate the dementia terrain. So from the stories I've heard and have been related to me, there seems to be a disconnect in care coordination within health systems. There seems to be what I'll call a gap between the clinical diagnosis of dementia and what comes next for the now caregiver in the equation. There's often little to no structured orientation to prepare loved ones for the caregiver journey ahead. And many new caregivers leave a neurologist's office, maybe where the diagnosis has been given, and they feel unmoored, untethered, kind of disoriented, confused, and uncertain about what comes next. And yet, they've got to navigate a disease that reshapes their lives in profound ways, and perhaps in ways they're not prepared for. So, Ashley, I'm eager for you to shed light on this issue and share how you're working to bridge the gap, assuming that's what you do in your position. I'm taking a guess at what I know and ensuring that, great. And let's ensure that loved ones stepping into caregiving roles receive the guidance that they need to navigate this terrain. So is that a decent way of teeing up the subject, Ashley?
Absolutely. I think you're hitting the nail on the head.
Okay. That's what I aim to do. So let's start. Maybe you can give us some background on who Ashley Trammell is and how did you find your way to Northeast Georgia Physician Group,
Yeah.
and tell us a little bit about your work.
Okay. Just a little background. I've been a part of Northeast Georgia Health System for 25 years, 21 of those in critical care. And honestly, I feel I was led here just, I would say, by just accident, but I really don't think it was an accident. I was searching jobs and found a cognitive nurse navigator position, had no idea what that was. Anyway, I ended up calling and got an interview, and I think I was the only candidate. So I ended up joining NGPG Neurology as the sole cognitive nurse navigator. That is how I got here. Now, this position was created through the Northeast Georgia Health System Foundation. The Northeast Georgia Health System Foundation supported this position. The neurology office found that patients and families were coming in, receiving a diagnosis, as you mentioned, and then after the diagnosis, they certainly had no one to guide them as to what's next. So the clinic saw this as a need, and also one of the foundation members had a personal experience with his wife who had dementia. And so, therefore, he was a big supporter of this exact position so that families and patients could have more support once a diagnosis was either given or that the clinic is working on getting a diagnosis.
Yeah.
So that is how I got here.
No, that is so interesting. And it seems like so much of the work that we do and the people that we touch, they're connected, as you just talked about the foundation member, they're connected to the disease in some way, shape, or form. I don't know if you're seeing an increase in the prevalence of dementia or it's just always been there and we're now seeing it more and more, but it seems to me it's yeah, what I characterize in my work with the Beyond Dementia Coalition and the Alzheimer's Association is a tsunami, if you will.
Yes.
Um, God, yeah,
Certainly a stigma surrounding cognitive diagnosis. Unfortunately, that's how it is in society at this time. It's not like, I feel like people will certainly share if they have cancer, certainly share if they have a heart attack. But when we are talking about cognition and memory, it is not shared as openly. And so, therefore, I believe there are many probably that are, not diagnosed yet. And I have about a monthly caseload of average about 60-ish new patients a month. And on top of that, I still continue to talk to patients from the previous month, patients and caregivers, I should say. It just depends on the situation. And that could range anywhere from, 50 plus. So it is a caseload of more than 100 caregivers, patients per month that I speak with. And yes, that is growing. That is absolutely
so,
growing.
so tell me more about your work as a cognitive nurse navigator, how that plays into. So let's set a scenario. Somebody's found their way to you, and I'm interested in how they find you.
Yes.
And also speak more to the stigma aspect of it and how you encounter it and how
Yes.
you address it.
Okay. So, first of all, I will explain how a patient gets to me. They see a provider in our office. Our providers determine when they will send me a referral. And then I either meet the patient in person and their family member, or more than likely, it's a phone call. We have 4 locations, so I can't see everybody. So most interaction is through phone calls. On the first interaction, I would say 9 out of 10 times I'm talking to a family member. I do that because obviously the person's coming in with cognitive concerns. So I kind of want, if I can talk to the patient also, that's fine too. But I also want to talk to a family member as well, because that's the person that's going to be supporting the patient through the journey. So I talk to either or both, and then build a rapport. I feel like building a relationship, letting the patient or family member know that I'm here for support anytime, email, phone, text, whatever. I want them to know that I'm available. I do not have the answer to all questions, but I will support them looking for resources and just listening. Many patients, many caregivers just want to be heard. And we certainly know in healthcare that it's limited time with the provider. And so I always want to make them feel that they have an unlimited amount of time with me so that they feel supported. And after I go through many questions concerning safety, what's going on in the home, do they have legal documents in place? What family support do they have? There's many questions that I go through to try to gain a better understanding of what's going on at home. And then at that point, I provide a resource list by email, depending on where they live, what their needs are. And then I follow up depending on need. Some patients I'm still talking to from 6 months ago are caregivers, either one. And some it is a one conversation and they know they can call me back whenever they need something or whenever something changes with their loved one. So I want them to make sure they know that it is open all the time, anytime. And I get plenty of calls and emails on the weekends too. Not often, but I do want them to know I can be reached at any time. So, and then as
Yeah.
far as yeah, and then as far as stigma goes, it's just conversations with family members and patients. But there was probably concerns that they've known about for a while, and they just I'm not sure why. They just feel embarrassed, maybe, that their cognitive abilities aren't what they once were. They can't participate with the community or their friends as they once did. So, therefore, I feel like they isolate many times because people may not know how to respond to their differing abilities. So it's certainly I just feel there's a stigma around it.
Yeah. And isolation, you hit on an important topic, is certainly, yeah, something that can exacerbate what's going on. It leads to further decline generally once you isolate. And the worst thing you can do is suffer from isolation. But so often
Yeah.
we've done some work in assisted living facilities with some programs that we've got, and it's clear that you can be sitting in a group activity, if you will. And a lot of the calendar in an assisted living facility is a group activity, but the person with dementia still suffers from that isolation. You can be sitting in a group of 100 people, and to a great extent, it's because of the stigma.
Hmm.
And so, yeah,
Hmm.
it's
And
tough.
yeah,
Go
and I
ahead.
feel it's just more education, just like Beyond Dementia is doing, how to respond. We shouldn't exclude, we should include, maybe modify how if you're talking about assisted living facilities or just people in their home in general with their family members. Sometimes it just takes some modifications to make that person feel that they have purpose. So that's what, I talk to families about because they don't know what they don't know. And so we try to just brainstorm many times how can we make that person continue to feel valued, continue to feel like they have purpose.
Yep, value and purpose. Tell me something more about the modifications you might recommend in a home.
What I usually tell people is it doesn't have to be super significant activities. It can be um, feeding the dog, feeding the cat, putting food out, watching the birds, sitting on the porch, calling an old friend or a family member. It can be many of those simple things. I think sometimes we reach for too many complex activities. Not to say that that can't be done as well, but it's okay to simplify things. And as far as modifications, I have a story. For instance, there was a patient who repeatedly was feeding her pet because she could not remember that she had fed it already. And anyway, the family had to end up giving the pet away to someone else because of what was happening. So obviously the patient was upset. Well, we substituted that real pet with a pet that you can even find on the Alzheimer's website. It's not real, but the person will see it as a companion, even though it's not their real pet anymore. They see it as a companion. So we modified that. They lost their real pet, but now we have something else in the place that they seem to be able to enjoy just as much, even though it's not a real pet. So that was one modification we made that turned out to be very positive for somebody.
Thank you for that. First of all, as a nurse on the floor within the healthcare system, there's something
Hmm.
called a care plan, right? Kind of the written roadmap for patient care. But sounds like I heard you mention what you do, and it sounds like you do have some sort of a checklist that you go through.
Yes.
And it seems similar, right? And it changes over time as well in terms of how you, in fact, help a caregiver navigate this terrain.
The care plan, it is ever changing, just as certainly there are care plans in the hospital at the bedside. This also offers a care plan, and it can change, as we know, daily, hourly. So that is why I try to encourage self education and having someone else to support you. I have many instances where I have just a husband and wife, and they do not have anyone else. So we work through several conversations many times of you have to have someone else to help you through this journey. You know, the care plan is ever changing many times depending on who the support person is and how many support people there are. So we also work to do different referrals, such as in-home palliative, which is a nurse practitioner and a social worker that can come out monthly for those that, do not are resistant to coming into the office or resistant to coming into the hospital anymore, for one reason or the other. So that's an option. We talk about hospice if the patient is at that level, talk through what that's about. So just try to provide different resources that may be available in different parts of the journey.
So it sounds like you've got your go-to resources. That was actually going to be my next question. If you've
Hmm.
got a wealth of resources, it sounds like to me that you can refer somebody to.
Hmm. Hmm. There are resources in the community, yes, but I do not feel like there's enough respite options,
Hmm?
such as day programs. That is lacking in many communities. I'm sure not just here in Hall County. That's in many communities. What is also lacking is many of my mild cognitively impaired patients who want to know more and still have the ability to be able to, I guess, maximize their abilities. I find that there is not support for those mild cognitive impaired patients, such as a support group for those type patients that are at the beginning of the journey. So I feel like that is a resource that is lacking.
So I find so often in the early stages of dementia and mild cognitive impairment, but I find there's often the aspect of denial.
Mm-hmm.
Do you find that, or is it a lack of resources, or is it denial?
Oh, yes, certainly there are many that are in denial. Absolutely. And, we talked through that. However, there are many that are not in denial and they are aware that their abilities are changing. And I've been asked many times, well, what can I do? Who can I talk to? We do have something called cognitive rehab at Regain here in Gainesville. And they do work with patients who are mildly impaired and have lost ability to do some things they enjoy or that is important to them. So we do send some patients there, but I still have yet to find a good resource for them to talk amongst their peers that are in the same situation. I don't feel like they have that support. We have all these supports for caregivers, absolutely. But for
Hmm.
that mildly cognitive impaired person, I don't know if there's something I'm missing too, and there may be something out there that I don't know about, but I have had that come up many occasions. And then the thing I can do with that, there are counselors. There is a couple that I will refer to. And certainly those in the mild stages I feel can benefit from that. However, going on into the moderate stages, counseling may not be as beneficial because of inability to retain information. So I do refer to counselors for that group of mild cognitively impaired patients.
That's great. I did have one more question. I'm assuming that also that there are those without the resources to help themselves. So you've got your resources that you might recommend, but social determinants of health, at least in my experience, play a big part in the ability of somebody to actually utilize those resources, lack of transportation, healthy food, affordability of services. Does that affect your work and the way you recommend?
Absolutely. I do ask in my initial discussion about finances because I certainly do not want to waste anyone's time because they're already overwhelmed. So, depending on their finances, I also point them in specific directions. For lower income, we certainly utilize Legacy Link in Hall County, and there's other ones depending on which county they're in. So we utilize Legacy Link referrals, and they are able to help many of our patients. And also, I utilize our social worker many times here at NGPG. I will refer to them many times. We have lots of conversations about um, different scenarios for a patient who may not have housing that is appropriate, who may not have caregiver support that's appropriate, and that they may need to go ahead and start looking for placement given that their cognitive issues will probably progress. So we certainly work together with our social workers. Sometimes we bring in adult protective services to help as well. So those are certainly the ones that are very difficult to manage. And we do what we can. We try to find any type of support we can to make sure those people are safe and well cared for going forward.
So, Ashley, what I'm detecting is your heart is all in on this as well, right? Sure,
Yeah,
sure, sure sounds like it.
I have a son with special needs, so I feel like I've advocated for him for 18 years now, and honestly, when I came into this, I didn't realize how similar it would be as far as needs and the caregiver aspect and planning ahead, all the things. So I think my personal story also helps me advocate for this group of patients just the same, if not more. So I do certainly have a heart for those with differing abilities. Absolutely.
No, thank you for that. And I think what I've learned in speaking to you as well as others that there's a real distinction to be made between the medical care that's delivered within a healthcare system and caregiving. And caregiving, to my mind, is the glue that holds us together. And that comes from a statement that Arthur Kleinman, who's a physician and an anthropologist, uses that term, the glue that holds us together. And he wrote a beautiful book, The Soul of Care.
Mm-hmm.
And it's about his journey with his wife, Joan, and her experience with Alzheimer's, and she passed from Alzheimer's. But care is a model for understanding.
Mm-hmm.
These are his words: reciprocity in relationships,
Mm-hmm.
even gift exchange that happens in a really very interpersonal and intersubjective space.
Mm-hmm.
And in the case of nursing care, and like yourself in the space of suffering, there is suffering that I think we need to acknowledge. So
Yeah,
thank you for the work that you do, and
you're welcome.
thank you for agreeing to this interview.
Yep.
Ashley, we'll talk soon.
All right. Sounds good. Thank you.
Beyond Dementia Coalition is on a quest to close the dementia preparedness gap we face. To get there, we sure could use your support as a donor or a volunteer. To get involved, please go to beyonddementiacoalition.org. All donations are tax deductible, and be sure to subscribe to our mailing list to receive our monthly newsletter in your inbox, where we'll share new podcasts, fact sheets, webinars, blogs, and other dementia-related content. This is Dementia Air. See the person beyond the disease.